My experience with near airway gadget. When the topic title was given to me, many things started revolving around me. And then I came to realize that we have come a long way in the airway gadgets, such as we are using conventional laryngoscopy, which is still a gold standard since 1940. In 1960, flexible laryngoscope was introduced. A revolutionary change occurred in 1980 with the invent of supraglottic airway devices, and another milestone was achieved in 2000 with the invent of video laryngoscope. Again, airway ultrasound or ultrasound machine is another revolutionary tool in the armamentarium of managing airway cases. Initially, every managing airway was skillful procedure done by every anesthesiologist, but now every intubation is been done in an artistic way. In my presentation, there is no conflict of interest. The photographs are taken only and only for the academic purpose. All the videos and photos I tried to cover, but sometimes some of the photos, the identity cannot be hid. So kindly accept the things. Talking on each and every airway gadget is out of scope of today's talk. So I'll be talking only on the clinical cases and utility of these gadgets in the clinical scenario. And the ultimate aim will be to keep you away from your airway gadget. The flow of my talk will be involving the newer airway gadgets which are used for ventilation and oxygenation purpose, those which are used for intubation, those which are used for extubation. These gadgets not only used in operation theater but can be used at remote locations such as cath lab, ICU, endoscopy suite. Coming to the ventilation and oxygenation device, we are well versed and regularly using these devices day in and out in our practice. What's new is this Ventrain device, and another is this ventilating mask. Now, coming to this ventilating mask, it is having great utility in the remote location, such as in the cath lab, in the endoscopy suite. You can perform TE, endoscopy, as well as fiber optic intubation with the help of this mask. These can be used on the frail patients, those patients who have less reserve, compromised, and are critically ill, in whom even a minimal amount of sedation will catastrophic effect. As you can see in this picture, I have used this mask in a cath lab where a cardiologist is performing TE, and I can give comfortably sedation to the patient at the same time ventilating as well as oxygenation is going on. Now, here in this case, I have used on this mask for fiber optic intubation. As you can see in the picture, the patient is having a 0-finger mouth opening. Patient was very anxious and not able to tolerate tropical anesthesia and was not cooperative. So this mask was used and a minimal sedation was given. As you can see, patient is comfortably breathing with the help of mask, and fiber optic bronchoscope being performed through the mask. The tube can easily be slid through this mask. You can just disconnect this connector once the tube is railroad and reconnect it to the circuit. About transtracheal catheterization, if we all know this assembly and it can be used in an emergency situation like CICO. What's new is this Ventrain device. Now, this is a smaller device which can be used for a single use. It works on Bernoulli's effect. There is an adjustable inspiratory flow. There is an active suctioning during expiration. This is a video which shows the utility of the Ventrain device. The catheter can be placed from front of neck. It can be connected to the auxiliary port of oxygen with 15 liters of flow of oxygen to be maintained. The another port is of this Ventrain device is connected to the tracheal catheter, and you can give inspiration as well as expiration comfortably to the patient. This is a very light handled device and you can use it in 360-degree position. It works on Bernoulli's effect. Some of the important devices which are must in the armamentarium of the airway cart are Stylet, Bougie, McGill's forceps. There is again a new invention in this Bougie. Even the flexi-tip Bougies are also available. Another innovation occurred here is video Stylet. Practically, I have not used video Stylet, but I have seen in 1 or 2 conferences. Something about video Stylet, again, many companies have come up with this video Stylet. And there is one paper which shows a case series report in which they have used this video Stylet for intubation in 5 of the difficult intubation cases. They claim that this can be used through the posterior or triangular area, even in a 0-finger mouth opening patient, the retromolar space. Another troubleshoot in this video Stylet is obstructive view by the soft tissue. There is difficulty to find the correct part to insert the tube. Blockade by the epiglottis, flogging of the lens, obstruction of optics by saliva, mucus plug, and blood. Difficulty to railroad the endotracheal tube into the trachea. The revolutionary change which occurred in the airway management is with the invent of supraglottic airway devices. These are very useful in CICO situation and for oxygenation, ventilation, and extubation. They can be used in cardiac arrest patient. For resuscitation, they act as a conduit aid of intubation. It is the best device to bridge the gap of bag and mask ventilation and endotracheal tube. There are again many devices come into the market, first generation, second generation, with some or the other modification in the device. The recent one are intubating LMA, fast track LMA, iGel, then LMA Proseal, Ambu Oragen, and the most recent is video LMA. What about the guidelines? You name any of the guidelines, LMA has its own place. Like difficult airway guidelines, the American and the IDA guidelines, the Canadian guidelines, or the emergency tool cognitive tool management guidelines. Airway is a second choice. It comes in plan B whenever your first attempt of intubation is failed. Again, with little modification of the devices, some useful devices are there like Gastro LMA, which can be used in the NORA, that is endoscopy stool. To give anesthesia to a frail patient for endoscopy or ERCP like procedures, and it is very difficult to manage on spontaneous respiration. So the Gastro LMA is another useful device. It can be used comfortably in the frail patients. As you can see, the endoscope is easily passed through the Gastro LMA. Here, the EUS scope, which is having a little bigger thickness as compared to the endoscope, can also be passed comfortably through the Gastro LMA. Hence, it's a very useful device in the NORA. Another device is this intubating LMA. Here, this can be used in CICO situation where your patient is not able to intubate or not able to oxygenate. So quickly inserting the LMA, ventilating the patient, and it acts as a conduit for intubation, and intubation may be possible. The only thing is you need to have a good mouth opening in those patients. Now, however sophisticated is the device, there are certain problems with supraglottic airway devices as well, such as displacement of the device, ill-fitting of the device, gastric insufflation, or regurgitation. So the third generation LMA come into market, that is Busca LMA, which has overcome all these flaws of the previous devices. It can be used as IPPV can be given without gastric insufflation. They made the opening a little smaller so that the risk of aspiration is minimized. There is additional tab on the Busca LMA, which can increase the angulation while inserting the LMA and hence negotiate the oropharyngeal angle. Again, there are additional suction channel port on either of the sides. So continuous suction can also be applied and risk of aspiration is reduced. There is additional ventilating port at the distal end as well. So it is a very useful device and it has overcome all the flaws of the previous one. Now coming to the technique of insertion. Well, I'll not go into the details because you all are well expert in inserting the LMA and using it on day in and out and right and left. By this, literally, I means LMA can be used for insertion with the help of right hand as well as with the help of left hand. Now, in some of the patient, there is some technical difficulty to introduce or induce the patient with LMA. In this, I have used Laryngoscope to insert the LMA, and this maneuver can also be comfortably done. Another technique is using a video laryngoscope for inserting the LMA. If you notice here the difference of video laryngoscope with that of the conventional laryngoscopy, you can see the cuff of the laryngeal mass fit into the oropharyngeal cavity. That can be seen on the screen. And hence, LMA can be inserted with the help of laryngoscope. Coming to the video laryngoscope. Again, revolutionary change in the airway management is with the invent of video laryngoscope. There are again many gadgets available in the market. Some are channeled, some are non-channeled. Whatever device you use, it has a great utility for intubation. It enhances the visualization. The first part success rate is maximum with video laryngoscope. It reduces the trauma to the airway structures. It can be used for insertion of RT, insertion to see the vocal cord movement, throat packing, and TE insertion. And the sequence is same as we do for the conventional laryngoscopy, like spotting the uvula, identifying the epiglottis. Here, the view need to be optimized so that everybody get engaged during the intubation. VL scope can be used for insertion of LMA as well, which I have shown in the previous videos. and probably it may be the gold standard in near future and will replace a conventional laryngoscopy soon. This would be an important gadget in not only in operation theater but in ICU, where there are a lot many technical issues, even in the NORA. Since last 3 months, I am using video laryngoscopes in each and every patient, and I found it very comfortable now. But initially, I had a lot of technical issue to use the video laryngoscope. Even the laryngoscopy was difficult for me with the McCoy's blade. To use Bougie does not mean that you are not skilled enough to perform on the intubation. While doing video laryngoscopy, Bougie is required or either Stylet is required, and the intubation can be very smooth. In this video, you can see beforehand whether whenever your tube slides and goes down into the esophagus before giving a minimal inflation to check whether the tube is in the esophagus or in the trachea, that minimal gastric inflation is also avoided, because on the screen you can see your tube is sliding down, and again you can remove it and redirect the tube into the glottic opening. Newer the device, newer are the problems. Here you can see in the initial period only I was stuck up. As you can see in this image, the pilot of the tube got entangled with the cable of the video laryngoscope. So when I tried to remove the video laryngoscope, the tube also came out. So such accidental things can also happen, and one must be very vigilant while using the newer gadgets. As I said, this involves everybody, and to assist for intubation, you can see the assistant is beautifully giving the cricoid pressure on the calyx manovia, the way and we required for optimal visualization of vocal cord. Gone are the days where we have to rectify that the calyx manovia is to give, or the cricoid pressure is to give on backward, forward, and right or left side of the pressure. So everybody in the team get involved while you are doing the laryngoscopy, and your assistant can assist you in a better way. This is the image till the date which I acquired, where I can see the esophageal opening as well as the tracheal opening in a very beautiful manner, and hence video laryngoscope can be used for teaching purpose in an institute and even for the non-technical staff. I have used this VL scope for insertion of DLT. As you can see, the passage of the first cuff and then the second cuff, and the required maneuver done at the distal end while passing the second cuff. So first attempt successful passage of DLT with the help of videoscope was done. Even TE probe can be inserted with the help of video laryngoscope. Here you can see the esophageal opening. And now the TE probe has been passed successfully. I hope it's appreciated. I also used VL scope for throat packing. Here in this video, you can see under perfect visualization, we can do throat packing. In our residency days, some part of the tube, some side of the tube remained uncovered, and so the chances of aspirations were more. So under video laryngoscope, you can literally visualize which part remains uncovered, and that part can be repacked. RT Riles tube insertion at time is a Herculean task, and I have selected particularly this video to show you the number of insertion of RT attempts had created a lot of trauma. So such type of traumas can be avoided by using video laryngoscope for first attempt passage of Riles tube. So in the first corner video, you can see throat pack been beautifully done. This part still remain uncovered. So again, you can redirect your throat pack at 12 o'clock position. And now the Riles tube has come. We can pass the Riles tube to the esophageal opening. This is one paper which is done by our own team member, Dr. Deepak Gorde. He did a multi-center randomized study in which he proved the use of video laryngoscope to reduce complication of by TE probe insertion. Another paper done by Divatia sir is direct laryngoscopy, an absolute one. But again, many more studies need to be there to prove VL scope as a gold standard technique of intubation. Coming to the fiber optic intubation, this can be the ideal indication is restricted mouth opening, difficult airway, precision of placement of endotracheal tube, and placement of bronchial blockers. But this requires an expertise and training, and the major crux of the successful fiber optic intubation is good tropical anesthesia and strong suction But there are causes of failure of fiber optic intubation as well. This may be because of secretions of blood, inadequate tropical anesthesia, decreased space, pharyngeal wall, distorted anatomy, inability to advent the endotracheal tube, or remove the fiber optic bronchoscope. These are some of the, I will call it as a simple, straightforward, and awake fiber optic intubation done at our institute. These are the patients and whom the mouth opening was restricted. There are some patients whose mouth opening was under 1.5 to 2 finger, but it was a dicey situation whether to intubate and fiber optic or laryngoscopy. But these patients were having CA tongue lesions and the tongue protrusion was difficult. So I opt for straightforward for the fiber optic intubations. Now coming to this patient particularly, he was operated 8 days back in the other hospital and came with the recurring lesions with a fistula. As you can see, there was a tracheostomy mark for this patient. So a lot of airway handling already been done in this patient. In despite of a good mouth make, it is always better to prefer an awake fiber optic intubation because of airway handling and tissue edema. Again, very frail patient with 0 finger mouth opening and distorted anatomy was a clear-cut indication of fiber optic intubation. This was a huge lesion which was again crossing the midline with a restricted mouth opening. Now, there are some intraoral lesions and there are some extraoral lesions. The lesions are so huge that you cannot even hold the mask. Despite of a good mouth opening, they are the patient for fiber optic intubation because holding the mask will cause trauma to this exposed tissue part. And again, bleeding might be the issue. So better to opt for straightforward for awake fiber optic intubations. This was a recently done case. Again, a huge lesion which was involving the lip and all the facial areas, and only one nostril was available for intubation. When I say awake fiber optic intubation, my patients are fully awake and they are being counseled very well that they will have a pressure sensation and little sort of pain. So they tolerate the procedure very well. But with good tropical anesthesia, the patients are very comfortable. As I said, my patients are awake. They means fully awake. And if you ask them, do they have any pain? They'll deny. They were quite comfortable even after intubation. One must be very vigilant while doing fiber optic intubation, especially in those patients who come for recurring surgeries or those who are subjected for radiotherapy or radiation therapy. These patients always give us a surprising fiber optic views. There might be chink-like opening, there might be tissue edema, there might be epiglottic edema and distorted anatomy. So another set of challenges occur with these patients who are subjected for radiation therapy. This patient I accidentally met has found out the vocal cord polyp, and the patient did not complain of any stridor or any difficulty in breathing. But there was a polyp on the vocal cord. So while discharging this patient, and we have mentioned that he should report to the hospital whenever he finds difficulty in breathing. So the safety of the patient is enhanced over here. Some of the challenging fiber optic intubation which I did in our institute is the bleeding and oral tumors. Actually, this patient was subjected 2 days later, but he came 2 days before with bleeding oral mass, and we need to plan him on emergency basis. If you look at the CT scan of this patient, there was a narrowing of the airway tract just below the glottis. So again, a different set of challenge to do fiber optic bronchoscope in this patient. Because of the narrow channel and you are passing the fiber optic bronchoscope through that narrow channel, it will have a choking like sensation. In this patient, there was a huge resection, and because of this, the tube also got exposed. So the injury because of the cautery occurred to the tube. So one must be very much vigilant in such patients. Because of the minute trauma, there was a leak. And if something like this happened in the middle of the surgery, we need to go for an afferent tracheostomy bang in the middle of the surgery. Another challenging case was this retrosternal goiter. She was a 55 years old female, came in an emergency department with stridor. She was not able to lie down. And on scan, you can see again a narrow down part of the airway. So this patient was done by Sujit sir, and sir did it intubation in a propped up position. Almost in patient was sitting and lying on the right lateral position, the position in which she was comfortable for breathing. And there was a complete narrow down of the tract. Again, here the choking, it was a bottleneck airway tract, and additional of fiber optic will create a choking sort of sensation. Such type of patients are more tend to go land up in respiratory followed by cardiac arrest. But it was successfully managed with the help of team efforts. Yes, this was the narrowest part. As you can see over here, this was the narrowest part of the lumen. This patient again is very near to my heart. She was an obese 120 kg patient, case of CA buccal mucosa, planned for free fibular surgery. As you can see, mouth opening was adequate. Anticipated little difficulty in airway management. So propped up position was given, Tenderlin-Buck position was given. Patient was very well oxygenated for 5 to 10 minutes. And I thought I would able to intubate this patient. So I gave the drugs, induction agent with propofol and fentanyl, and checked the ventilation. Patient was able to ventilate. Then I gave scoline. As soon as I gave scoline, patient was not able to ventilate because the airway collapse had occurred. So she turned out to be a difficult case of physiological difficult airway. And it was very difficult to ventilate. So I thought better to intubate, let's see, do a laryngoscopy and try to do a intubation. But again, it was Korpman-Lehan 4 and not able to see anything. The first attempt when it was an esophageal intubation. Then I again hold the mask, try to ventilate the patient and give apneic maximum flow of oxygen, and somehow brought the saturation up to 83%. So our plastic surgeon as well as oncosurgeon was operating in the next OT. I discussed with them about the plan because she was planned for free flap surgery. Tracheostomy might be needed because the flap would be bulky in the postoperative period. So after discussion, we came to the conclusion and opt for front of neck access preoperatively or before starting of the surgery. So on the second day, we both turned the thumb because we came out of the storm comfortably. This again within after 2 months, and this patient came to us for CA buccal mucosa, and she was again planned for free flap surgery. But again, the previous experience of physiological difficult airway, and so I straight opt for awake fiber optic intubation in this patient. This patient was planned for MRM surgery. She was having some flexion deformity. You can see flexion of the elbow, flexion of the knee joints. She was having a rheumatoid heart disease, and this was the only extension of neck possible for her. She was having a good mouth opening. So I tried to intubate the patient, but again, it was an esophageal intubation. And then I opt for inserted an LMA in this patient, and the case was done comfortably on LMA. Now, I want to give one message on this slide that if we think of this patient, we had and opt straight away plan D, that is front of neck access, because this patient was planned for head and neck surgery. The patients are always counseled there will be tube in situ or else and front of neck access will be taken. But if some patient come like this for a minor surgery, for a daycare procedure, you cannot go directly jumped onto the plan D. So you need to follow the guidelines, and hence plan B was opt for this patient. So one must be very precision to decide which case need to follow what sort of decision. This was the only case till the date came to me with a dynamic airway obstruction. He was an ambulance driver. He had prior history of choking. So the RMO with him, he gave the Silixmenovir. That day, there was no event. But next day, he went to an ENT surgeon and endoscopy was performed. And there was a flip-flop movement of the vocal cord polyp. He came to us for removal of this polypectomy. Now, again, despite of having this video with me, I again did fiber optic bronchoscope. I asked the patient to cough out. So while coughing, the polyp was coming out. Then I could get some passage through which the tip of the fiber optic bronchoscope can be negotiated. So the major crux in managing such type of patient is not to give transtracheal, because you want the patient to cough and so that the polyp falls away from the glottic opening. So that was the mobile vocal cord polyp. Again, fiber optic bronchoscope can be used for placement of bronchial blockers. In this video, you can see the bronchial blockers are beautifully placed. You can see the flange at the carina. You can see the cuff inflation and deflation. And hence you can confirm that the bronchial blocker has perfectly been placed. Yes, you can see the cuff been inflated. Now, some of the cocktail methods you need to try as per the case base. So in this patient, again, she was having a fistula, a post-radiation fistula, limited restricted mouth opening, and mass ventilation was difficult in this patient. So I opt for awake fiber optic intubation. But again, to negotiate the tip of the fiber optic bronchoscope was very, very difficult. And hence I inserted the laryngoscope with the difficulty and again guided the tip of the fiber optic bronchoscope through the glottic opening and then railroad the tube. So such type of cocktail methods also you need to do whenever there is a difficulty. This video, there was again a case of head and neck surgery, and our surgeon wanted nasal intubation. She was not planned for any major surgery, so FONA was not an option for this patient. I found it very difficult to pass the nasal tube. Then patient started desaturating, so I secured the oral tube. Once the patient was ventilated good, then I again tried for nasal intubation with over the Bougie. It takes a lot of courage to show such type of videos on such a prestigious platform. But in this video, I wanted to show you the non-technical skill of your team. You need to develop your team in such the way you want them to help you in the crisis. If you can see, one person is constantly giving cricoid pressure, he's not had removed his hand. One person is assisting me with the Bougie, the another one with the tube, another one is holding the suction. One person is announcing the saturation because I'm not able to see the saturation. So he's constantly announcing the saturation. So that sort of teamwork you need to do in case of crisis. And you need to do the briefing and debriefing of your team after every intubation. Yes, here finally I could railroad the tube over the Bougie. It took me around 3.5 minutes to intubate this patient. Some of the DDDs, that is difficulty to deal the difficulties. Already you are dealing with a difficult airway and there are again additional difficulties. So again, this was the case where again nasal tube was not able to pass. So I put in the tube only till the oropharynx, then guide the Bougie through it. Again, you can see the Bougie was hitting to the anterior tracheal wall over here. With the slightest maneuver at the distal end, the tube was able to pass. I wish I could have a flexitip Bougie over here to do this case. In this patient, again, when I put in the nasal tube, the tube had passed through an adequate length, but it didn't turn out into the oropharyngeal region. So I just removed it and passed it to the other nostril. But I just wanted to know where it went. So I just checked Fibreoptic Bronchoscope in this patient, and you can see it had created a false passage. Yes. So this was a false passage created because of nasal intubation. So one must, if there is a resistance, one must not keep on passing the tube. So such type of trauma can also occur. Coming to the ultrasound. Ultrasound is another modern gadget, must be there in the armamentarium of Airway because it is safe, non-invasive tool. It is a portable device, can do a dynamic assistant, a real-time image and can be there. But one must be familiar with all sorts of imaging. So that can be used for airway assessment and upper airway anesthesia, proper ET tube selection, confirming the placement of depth of the endotracheal tube, identifying cricothyroid membrane, assessing the vocal cord movement, post-extubation striders, and gastric volume assessment. How I have implemented the use of ultrasound in my practice is while doing the head and neck again in surgery and giving a transtracheal for a fiber optic intubation. Whenever you get a clean anatomically patient, lean thin patient who have a beautiful anatomical structure, the ultrasound also shows a beautiful picture. You can easily identify the cricothyroid membrane and the string of pearl appearance. So I tried to give transtracheal with the help of ultrasound as well. This definitely increases the precision of prick, taking the prick at the region, also avoids the posterior tracheal trauma. Here you can see the jiggling movement. Yes. So that is the jiggle movement of the needle while giving transtracheal. Local infiltration. Now in one patient, I faced the difficulty to give the transtracheal. This was a patient who came with recurring lesion and he received radiation therapy and he developed the radiation burns. The neck and the chin was stony hard. I was not able to identify the structure, not able to palpate anything on the anterior part of the neck. So ultrasound helped me to give transtracheal in this patient. As you can see, the prick was bang lateral for giving the transtracheal. So in this way, those patients who are not having a perfect anatomical structures, you can definitely use ultrasound to give the transtracheal. Now, few of the ultrasounds which I have scanned, this patient, you can see the lesion and you can again identify lesion on the neck and midline being shifted. The TECA structure is, the anatomy has been distorted in this image because of the recurring lesions, the thyroid cartilage and the cricoid cartilage. Again, you can see in this slide, the airway anatomy is distorted. So again, patient was for recurring lesion. There was, you cannot identify the thyroid cartilage, neither the air mucosal interface. This patient, again, I scanned for routine airway as I do for routine airway scanning, but accidental detection of hematoma. The patient was tried for IJV cannulation in ICU and it was a failed attempt and there was a huge hematoma notice. So definitely airway ultrasound and neck ultrasound will definitely add information in your clinical practice. This was a case of cystic hygroma. He was an obese, more than 100 kg with restricted mouth opening, and this was only neck extension possible for him. He was with lot many comorbid conditions. Actually, the plan A was awake fiber optic intubation in this patient, but beforehand we marked cricothyroid membrane. So if at all, if that intubation plan A fails, our plan B was directly front of neck access. Now, any airway topic cannot be complete without including front of neck access. Either you can do it with the age-old technique of transcannulation or with the recent techniques such as scalpel Bougie technique, Seldinger's kit technique, or percutaneous tracheostomy technique, even tracheostomy. Now, how I implement the tracheostomy, these head and neck patients, whenever they were planned for tracheostomy in postoperative period, I requested the surgeon and assisted them and learned the technique of tracheostomy. Now coming to the extubation. Whenever there is a difficult intubation, it has to be a planned extubation. So the devices which are used for extubation are airway catheter, high flow nasal oxygenation, CPAP, ultrasound. Through the ultrasound, you can detect the air column inside the air mucosal interface, which will give you idea that patient may land up in striders. Bell's maneuver. It is very essential. Whenever you think extubation is going to be difficult, and Bell's maneuver should be tried. Keep the patient in a deep plane of anesthesia with endotracheal tube in situ, and you need to place LMA just behind the endotracheal tube. Connect the circuit to the LMA and remove the tube. In this way, you will avoid all the stress response untoward event of laryngospasm in those patients who are difficult for extubation. One slide about high flow nasal oxygenation, even though it is a device which is mainly used in an ICU, but you can definitely use in a perioperative period. Recently, I used this in 87 years old female was planned for a biliary stenting. So patient, as soon as I gave only 25 mics of fentanyl, patient desaturated. And so high flow nasal oxygenation was applied and patient saturation returned to normal within few minutes. So in this way, perioperatively also you can use this device. So finally, airway management is the cornerstone of anesthesia and resuscitation. Too many devices are being introduced into the market. Adequate depth of knowledge and training is essential. Newer things should be tried only and only in ASA grade 1 patients with expertise we can use safely in difficult cases. Combination of multiple airway devices is also known as multimodal approach, and can be done in a complex airway cases. Including the technical skill, one must learn the non-technical skill as well. You need to train your team so that they can help you in crisis. And after every difficult case, briefing and debriefing must be done. Follow the guidelines, and declaration of failure of one plan is essential so that we can plan for next B, C, and D for successful securing airway. All techniques are susceptible to failure, so note the greatest number of alternatives to treat even the most challenging airway successfully. And finally, most of these cases are done at a single institute, and I must acknowledge our Ozone Anesthesia team as well as our surgical team, because of we get day in and out such challenging cases. You will find the related videos to this topic on our YouTube channel. Please do like, share, and subscribe. A complete difficult airway workshop series is also available on our channel. Thank you very much for your patience listening.